So we are good to start. We are already live. So with all your due permission, can we begin?
Oh, yes, please do.
Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With great pleasure and honor, I would like to introduce our keynote speaker, Doctor, for today's session, and he's none other than Dr. Rajesh Jindal, sir. Sir is MD in Radiotherapy, consultant at Medulla Cancer Cure Center, Agarpara. With the help of sir, we'll be taking a close look on today's topic, which is nutrition support in cancer patients. Before moving on to today's session, let us have a brief look on what the topic says. Cancer is a complex disease and is regarded as one of the current leading causes of mortality worldwide. Metabolic and nutritional alterations due to cancer-associated malnutrition, sarcopenia, and cachexia can influence the survival and recovery of cancer patients. Now, without any further delay, I would like to welcome Sir so that he can give us an overview about the topic with his wonderful insights. Sir, over to you.
Thank you very much. And good afternoon, everybody. I would like to say that today is the Bengali New Year. So wish you all a very happy New Year. And may you look into prosperous and more happy times than what you are in as of now. So without much anything else, I would like to start on my topic, which is nutrition support in cancer patients. Very important thing, as you said, because most of the times we are at a loss to understand why did this happen and how should we go about improving upon it and to help our patients. So accordingly, the next slide would be about cancer-associated malnutrition. What is the etiology of the whole thing? Why does it occur in the first place? Well, there is a huge mismatch between the central and the peripheral catabolic and the anabolic drive in these patients. This is attributed to the various tumor-related products, maybe because of the inflammatory response which is induced by the tumor in the body, or it could be the various substances such as cytokines, interleukins, prostaglandins, tumor breakdown products, peptides, and maybe bits and pieces of hormones and other substances, which cause a change in the internal environment of the body, and it gives rise to malnutrition. It gives rise to loss of appetite, loss of weight in these patients. So the indications for nutrition therapy and just give is pre-cachexia or if there is cachexia. Now, rate of increase breakdown of protein without weight loss. So apparently what the body is eating compensates for the increased breakdown of protein, but then this patient actually can this condition be diagnosed clinically? Well, you can only ask the patient, you can only see, evaluate, see the extent of the disease, and then maybe you can arrive that yes, he may be in a pre-cachectic state, simply because it is confusing because he is not actually losing weight. But then the other side of the coin, cachexia, is the actual loss of weight, muscle mass, and so on and so forth, so that it becomes a complete and a very obvious indication for nutrition therapy support in cancer patients. Now, nutritional support may be to provide macronutrients, micronutrients. A patient might need a high protein diet supplemented with proteins. He might be anemic, so you supplement it with iron, so macro and micronutrients. To provide nutraceuticals or drugs that interfere with the tumor-induced metabolic change. It may be a combination of both. You may have to do both number one as well as number two. So what is a nutraceutical? Well, a nutraceutical is any substance, food, or a part of food that claims to have medical and health benefits including prevention and cure of disease. A very apt example would be you take the fruit, either the whole fruit or just the skin of the fruit or just the seeds of the fruit. So it could be food or it could be a part of the food. The drugs which can help would be either metformin, hydroxychloroquine, and maybe others as well. What are the goals of nutrition therapy in these patients? I mean, what exactly are you looking for if you want these patients to eat and you want to intervene in their eating parts? Well, it is to enable the patients to initiate and to complete the cancer treatment. It may be surgery, it may be chemo, it could be radiotherapy, it could be a combination of any one of these three modalities of treatment. And it should enable the patient to lead a good quality life and to carry out his or her daily activities at the least. Well, if you can inspire or if you can feed him enough so that he goes to work, nothing like it. What are the routes of administration? Well, we all know the routes of administration, how we can eat food or how we can make somebody else eat food. Actually, dietary counseling and oral route work the best in cancer patients. It will give him a sense of appetite. It will give him taste. It will give him the satisfaction and the courage that yes, he can still eat and he can still maintain a good weight. Otherwise, we switch over to enteral nutrition, which could be either a nasogastric tube, it could be a feeding jejunostomy, a feeding gastrostomy, and maybe other such ostomies. And then lastly, it could be IV feeding, which is parenteral nutrition. Enteral route, when is it indicated? Oral route, we all know when is it indicated. It's indicated in everybody. So enteral route, where is it indicated? Well, it may be in persons, in people who are not able to eat because of the side effects of treatment. It could be nausea, it could be vomiting, stomatitis, especially after an infusion of 5-FU, taste, altered taste, maybe due to the infusion of the platinum compounds. You get a metallic taste in mouth and the patient is not able to eat anything. Cancer cachexia, as we have already discussed, that cancer cachexia is an indication for food supplementation to make the patient eat. It may be altered physiology due to cancer surgery. Cancer on the stomach, partial gastrectomy, full gastrectomy, or that the intestinal length has been shortened. He's got a right hemicolectomy done, he's got a colectomy done, he's got a left hemicolectomy done. He could have had a Whipple's done, removal of the pancreas, or he could have a cholecystectomy done for a G cancer. If you have altered anatomy, if there is anatomy on the mouth, jaw, or the palate, then the patient, he might not be able to eat at all. So in that case, you may have to supplement his eating. Enteral route is preferred simply because it is more physiological. There are less complications, especially infections. Obviously, there is nothing piercing the skin. You've not made any other body. There will be less of infections. There is less frequent hyperglycemia in these patients. You can also control the quantity of sugar which goes in. I'll show you how subsequently. It is more cost effective than the IV feeding, than the parenteral feeds which are available in the market. And it can improve the nitrogen balance and actually cause a weight gain in these patients. Well, if there are indications, there would be contraindications as well. And to the enteral route, they would be if there is an obstruction in the bowel. Now, if there is a bowel obstruction, then whatever enteral route you employ is not going to help. So if there is a bowel obstruction, again, there is nothing which moves through the GI tract, so you can't make him eat orally or through an input. abdominal distension, it could be for all you know. GI bleed, well, one of the mainstays of GI bleed treatment is to keep the patient NBM, nothing by mouth. If there is severe diarrhea, in which the GI acts like a hose pipe, you put in at one end, comes out at the other end, there's no absorption, there's no nothing, you have to make the patient live. But then if he's got severe diarrhea, enteral route is not going to work. And if you have high output external fistulas, so enteral route is contraindicated. It's not going to work over here. Parenteral route, well, when the GI tract cannot be used, and it cannot be used in all these conditions that we just saw. So when you have the inability to use the GI tract, or in severely malnourished patients where he will not tolerate oral feeds, or maybe he will not tolerate any enteral kind of a feed in those things, we would use the IV feeding route for these patients. Well, what are the benefits of oral and enteral therapy versus IV nutrition? Well, in the first place, it maintains the gut mucosal mass, because everything is still being poured into the gut, and the gut mucosa has a reason to function and to perform and to serve its master. It maintains the brush border enzyme activity, and it supports gut immune function. This point, number 3, is assuming a lot of importance these days, that it supports gut immune function, because it is said that it helps if you have a proper GI tract in the effectiveness of the immune therapy also. So you have these immune checkpoint inhibitor therapies. So if you have a proper GI tract functioning, they say it also helps over there. It preserves the gut mucosal barrier function, and it maintains balanced luminous is to start feeding him as soon as it can be done. As soon as I believe we get the bowel sounds, then the patient can be started on increasing doses of food, increasing quantity of food, starting from liquids to semi-liquids to solids. Parenteral nutrition, it should be given 1 to 2 weeks prior to surgery in moderate to severely malnourished patients, so that they can be brought up for surgery, they can be built up for surgery, so to say, and that they can be operated upon successfully. In the post-op period, or the oral and enteral therapy, as I said, ASAP after surgery, and in the IV feeding patients, parenterally fed patients, post-op would be as needed. Now, nutrition prescription, what kind of food, what kind of composition are you looking into? Well, it depends upon the patient's age, sex, the body structure, the energy requirement of the patient, what was his levels of energy before, the level of activity before, I'm sorry. So you can, the protein requirement is 1 gram per kilogram per day. I will not say per kilogram in every time, okay? So the protein requirement is 1 gram per day, per kilogram, of course, and 25 kilocalories should come from non-protein sources. So it can come either from carbohydrates or from lipids. The essential fatty acids, linoleic or linolenic acids, are about 1 to 2 grams per day, per kilogram, of course. And you can add fluid to it, electrolytes to it, vitamins and minerals to all these substances. The finished product will have 1 to 2 kilocalories per ml, and the average feed would be about 1500 to 2000 kilocalories per day. So that is the the composition of the mixture. Now, several enteral formulas are available, like anything, like you have all kind of drugs available in various brand names. So you have all kinds of formulas available, and the selection will depend according to the nutrient and the fluid requirement of the person. You start with 30 ml per hour and increase it at set intervals. Either increase it every 12 hours or you increase it every 24 hours to reach the desired level, both in terms of the energy requirement as well as the fluid requirement. And if you increase it every 12 hourly, it comes to 360. The next day, after 12 hours, it becomes 720, and after 12 hours, it becomes 1440 ml per day. Now, parenteral nutrition, well, these fluids are hyperosmolar fluids, and they would need parenteral access, of course, and preferably a central line. So it could be a central line, it could be given via a port, it could be given via a PICC line. These formulas contain 1/4 glucose. So the composition is that 25% of these formulas, they are hyperosmolar. So they contain glucose, 25%. Amino acids would be about 4.25%. Add to it essential vitamins, minerals, and trace elements. Volume would be about 2 to 2.5 liters, and the output is the caloric density is about 1 kilocal per ml. And while on IV nutrition, parenteral nutrition, patients should receive at least 500 ml of a 20% fat emulsion containing the essential fatty acids, linoleic acid and the linolenic acid every week. Now, I missed out on this slide. Yeah. Now, you do have something called the immunity enhancing formulas, which are available in the market, off the shelf, of the counter. They contain arginine, glutamine, and they contain RNA, plus minus omega-3 fatty acids. Now, from here on, it is, well, they may reduce post-op infections, they may shorten the hospital stay. So these are the only two recommendations that I have for these immunity enhancing formulas. If they say that it may reduce, you have evidence either way, may or may not, and it may shorten hospital stay, it may not shorten hospital stay also, but then the jury is still out on this score. Now, what about glycemic control in cancer patients? This is important. We must target a blood sugar of about 140 to 180 mg per deciliter. Anything less than this will increase the incidence of hypoglycemia, increase the mortality in these patients independent of hypoglycemia. So this blood sugar level of 140 to 180 is regardless of the diabetic status of the patient. So this is about the glycemic control. Now, what do you do for patients who are not on active treatment, but they would still require palliative parenteral nutrition support? The indications would be bowel obstruction. If the patient is not able to, if the gut is obstructed, so to say, then how do we feed him? There's no way except IV that you and I can feed him. If he's got a fistula, you give him something to eat and it comes out of the fistula. Doesn't make sense at all. Malabsorption. He is not able to absorb anything from his GI tract. Or it is radiation enteritis. And radiation enteritis is a very, very bad thing to have, trust me. So these patients will not be able to take anything orally or retain anything in the gut, so that they would need PPNS, which is palliative parenteral nutrition support. Now, who are the people who would be benefited most with PPNS, palliative parenteral nutrition support? These would be patients who already have a good performance status. They are at least able to do their daily chores without help. They are able to get out of bed by themselves, go to the loo by themselves, wash themselves, take a bath, eat themselves, maybe take short walks. And the other people would be if they have an inoperable bowel obstruction. I mean, there is, the patient has a bowel obstruction, but the general condition is such, or the disease is such that he or she cannot be operated. There are minimal symptoms from the metastatic disease of major organs. The patient has extensive involvement of the lungs, liver, bone, brain, but fortunately, he's not so symptomatic. There is a problem with his eating and all, right? Not able to eat, not able to retain. So these are the patients who would be helped with the PPNS system. Or if you have a progression of indolent disease, like I can explain the inoperable bowel obstruction over here. There are certain low-grade lymphomas which just grow and grow and grow. They are not amenable to any kind of treatment. Retroperitoneal region, in the abdominal region, they can cause gut obstruction. They are so widespread, so much infiltrating that they cannot be operated, and yet they cause bowel obstruction. So these are the people which will be helped by palliative parenteral nutrition support. Then comes PPNA should be offered only if the patient is a candidate for active cancer treatment. The patient has got lung metastasis, the patient has got brain metastasis, liver metastasis. He's not able to eat for that, for those few days. I think in that case, these patients should be given PPNS offer so that if the general condition builds up, then he can be taken for subsequent treatment. This is what it means over here. If the expected survival is more than 40 to 60 days, in that case, I mean, you can evaluate the survival of the patient. And if you think that he's got more than 6 to 8 weeks to live, or maybe 60 days, mein kitna din ho jata hai? 10 weeks to live. So in that case, he should be offered PPNS. And above all, if he has a caretaker support for nearly 24 hours a day, IV feeding is not an easy thing to have. It is not just an IV running into you. There are tubes which are going in and out of the body. There is a bottle hanging on the top. If you move about, if you do this thing, you have a fear of dislodgement, extravasation, and all those things. So these people need help and expert supervision. Now, having said all this about PPNS, does it actually help? Well, there is evidence, unfortunately, that PPNS in end-stage disease is futile and may actually be harmful. So that is where we stand with PPNS. The few indications where it helps are these: only if the patient is a candidate for active treatment, if the expected survival is more than 60 days, and if there is, well, this one is not exactly an indication. The third one is a condition, in fact. So now, what is the effect of nutrition on tumor growth? Very important topic, and most people will ask each other. Well, nutrition support undeniably may enhance tumor cell growth and protein synthesis. So if it helps the host, it will help the disease as well. However, there is no data, clinical data, on the outcome of nutrition support in malnourished patients on the tumor growth and the spread of tumor. So you feed a patient end-stage cancer, the patient is on nutrition support. Does it help the tumor to grow faster? Does it help the tumor to spread faster or spread more? The jury is still out. We don't know कि क्या होता है इसके अंदर में. But the status of the recommendation is that it is recommended. The nutrition support is recommended because at the end of the day, you and I are looking into the welfare of the patient, right? Whether it also adds to the welfare of the tumor, that is a very open question as of now. So I think this was my last slide, and thank you very much. Thank you.
Thank you so much, sir. Thank you for your valuable insights that you have shared upon the topic and for briefing our viewers all about the topic. We have received few questions from participants and I would like to put it across to you.
Yes, please do.
The first question is, what diet people should follow who have constipation during cancer treatment?
Yeah, that is a very interesting and important question that you asked. You know, if patients have constipation during cancer treatment, most of the time it is either because the patient is not able to eat an appropriate volume, or it may be drug induced. So get in touch with your physician. However, I prefer that we use local means to get rid of the constipation. And by local means, I would say I would use maybe a suppository. It could be a glycerin suppository, it could be Dulcolax suppository, or it could be, and only if these things don't help, then I would advise patients to take something by mouth. I mean, any laxative by mouth, that is what I would do. And start with the natural products first, start with a mild laxative first, isabgol or something, and then you can graduate on to other things. So if the constipation is actually worrying, if it is actually bothering, then you can ask for treatment. And you should ask for treatment for that matter. Yes. Thank you for the question.
Thank you so much, sir, for answering the question. We'll move to the next question that we have received. And the question is, people experiencing nausea during chemotherapy, what diet is good for them?
Again, a very pertinent question. See, nausea most of the times is triggered by the smell of food. And if the patient has nausea while on treatment, it could be chemo, it could be radiation. What we people advise is that he should take in a bland diet. And whenever I say he, it means both, he or she both, right? So this person should take in a bland diet without any smell and preferably a bland taste. It helps, right? If these things don't help, then you ask for pharmacological treatment, take in drugs which your doctor advises you, and then you go ahead with them. But nausea, yes, it is an issue, but not unsurmountable. Thank you.
Thank you so much, sir, for answering the question. We'll move to the next question that we have received. And the question is, does high sugar intake increase risk of cancer?
See, if you ask me, does high sugar intake increase the risk of cancer? I would stretch the argument towards obesity. High sugar intake usually would lead to obesity. I may be partly correct only in this assumption, but then yes, it might lead to obesity, and obesity is known to predispose to cancer. So that way they are related. Now, whether it is a direct one-on-one effect or what, how does it work out? Well, I'm not very sure, but then yes, increased consumption of sugar leading to obesity will predispose you to having more cancers. Yes. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next and the last question for today's session. And the question is there anything people should or should not eat after treatment?
After treatment?
Yes, sir, after treatment.
Well, after treatment, what we should not eat and
what people should or should not eat.
Okay.
Do's and don'ts.
Okay, fine. So let me start with the should first. Okay. For what you should eat, we got a very succinct this thing. Your food should be Shuddha Shakahari Sattvic Bhojan. Okay, which will contain plant products, lot of fruit, lot of vegetables, cereals and other things. Stay away from meats, stay away from red meat, and stay away from these things. All right. So what you should eat is Shuddha Sattvic Shakahari Bhojan. What you should not eat is Mansahari Bhojan. That would be eating red meats, dairy products, alcohol, smoke, tobacco, and so on and so forth. Thank you.
Thank you so much, sir, for answering all the questions. That was the last question for today's session. And I would also like to thank all the viewers for their ardent participation that they have shown throughout the session by staying tuned with us. With all your last comments, sir, we can conclude the session here for today.
Okay, so what I would tell to all my audience over here, nutrition support, treatment, and chemotherapy, surgery, radiation are all good. They all have a place for themselves. They all have their assigned places in the hierarchy of cancer treatment. But please be self-aware. Examine yourself, see yourself, read about the early warning signs of cancer, right? Get your young girls vaccinated for cervical cancer. Quit smoking, quit alcohol is all that I can say as a parting shot. Thank you.
Thank you so much, sir, for your valuable remark on this topic and for such wonderful insight that you have shared. We would be concluding the session here for today with all your due permissions.